Thank you. And welcome. Welcome to the final plenary of the 2017 RCGP Annual Conference. I think this conference has had a real buzz around it. And what we've noticed particularly is GPs of all ages networking and contributing to the workshops and discussions. And it's been so good to see and to feel. This morning's plenary is busy. We have a number of presentations that include prizes and keynote speakers. It will be interactive, so you will be asked to participate in polls via Slido during the presentation by Jaco Burgers. That's available via the app or at slido.com. And the room code, if you need it, is Saturday Plenary. And please don't forget the Twitter hashtag at RCGPAC. A health and safety announcement before we kick off. In the event of a fire, please leave your belongings and leave via the clearly marked fire exits where venue staff will guide you to the designated meeting point, and please don't use the lifts, and I'm sure you will all survive. Let us kick off then with the announcement of the Research Paper of the Year. This is the annual Research Paper of the Year award. It's now in its 21st year. It gives recognition to an individual or group of researchers who've undertaken and published an exceptional piece of research relating to general practice or primary care. There are 6 category awards, and 5 of them were delivered in the winner's enclosure a couple of days ago. But the award winner today, who has one out of 87 research papers entered for this award this year, which is amazing, is titled, it's for the category 4, Neurology, Mental Health and Dementia. The title of the paper is Long-Term Effectiveness and Cost-Effectiveness of Cognitive Behavioral Therapy as an Adjunct to Pharmacotherapy for Treatment-Resistant Depression in Primary Care, a follow-up of the COBALT randomized controlled trial. It was published in the Lancet Psychiatry in 2016. The lead author is Nicola Wiles, who we'll call up in a second, and the GP authors in the group are David Kessler, John Campbell, and Jill Morrison. So if Nicola Wiles could please come up to receive her award, and I'd like to introduce Dr. Terry Kemple, our president, to actually give her the award. Thank you, Terry.
Congratulations.
Thank you very much. Thank you.
Now I'm going to ask Nicola to give a very short presentation so that you know what's actually in the content of her paper, and then she'll come over to answer a few questions from me.
Okay, so thank you very much. I'm delighted to share the results of this research with you this morning, and I'm presenting very much on behalf of the COBALT team, who involved a range of academic GPs, psychiatrists, psychologists, trialists, statisticians, and health economists. I'd also like to just briefly acknowledge the wider COBALT team who were involved in the original trial, not all of whom were involved in the follow-up, our funders, NIHR, and the declarations, as you can see here. Okay, so as you all know, non-response to antidepressant medication is a substantial problem in primary care. And we found that over 50% of patients with depression who'd been treated with medication for at least 6 weeks continue to have substantial depressive symptoms despite this treatment. So in the original COBALT trial, we found that cognitive behavioral therapy was an effective adjunct for this patient group over a period of 12 months. Now, we know that CBT is an educational approach. It's about teaching patients skills to help them manage their mood in the long term. And so what we wanted to ascertain was whether there was any potential for benefit beyond the end of therapy. And if we look at the literature, there is very little evidence around long-term effectiveness of cognitive behavioral therapy. That which exists mainly relates to relapse prevention. So in this long-term follow-up of the COBALT trial, we followed up those individuals who were originally randomized into the trial, so that was 469 individuals, and these are patients who were between 18 and 75 years, who were taking antidepressant medication and continued to have significant depressive symptoms following at least 6 weeks treatment, and had adhered to that medication. And they were randomized to either receive 12 to 18 sessions of individual face-to-face CBT, as well as their usual care, or to continue with usual care alone. And everyone who was recruited to the Cobalt trial was taking antidepressants at the point of randomization and expected to continue to do so as part of their usual care. As you can see here from the slide, those patients who were recruited to Cobalt hadn't responded to antidepressant medication, and they had depression which was both severe and chronic. So nearly a quarter met ICD-10 criteria for a severe depressive episode. Their current duration of depression had lasted more than 2 years in around 59% of individuals. And in fact, 70% of them had been taking their current medication for at least 12 months. So the primary outcome for our trial was self-report depressive symptoms on the Beck Depression Inventory. And this graph here shows you the mean BDI scores at 6, 12, and 46 months. And as you can see here, those in the CBT group, which is the line in red, had substantially fewer depressive symptoms over the course of this long-term follow-up compared to those who received usual care alone. And this equated on average over the 4 years follow-up to nearly 5 points on the Beck Depression Inventory. And so this was a duration of over 4 years, which equated to around 40 months after the end of therapy for those who received CBT. If we look at the secondary outcome of response, which was a 50% reduction in depressive symptoms, we saw that those who received CBT, actually 43% of that group met criteria for response compared to 27% of those in the usual care, so equating to nearly a 3-fold increased odds. So in other words, those who received CBT had a 3-fold increased odds of meeting criteria for response, or a 50% reduction in their depressive symptoms over the course of this long-term follow-up compared to those who continued with usual care alone. And in addition, we found benefits in terms of reduction in symptoms of anxiety and also improvements in quality of life over the long term. So the clear benefits for the patients in this trial. And importantly, we also found that this treatment represented good value of money from the perspective of the NHS. The key figure here is the cost per quality adjusted life year gain, which was just over £5,000. And this was well below the threshold of £20,000 per QALY, which is used by NICE to judge cost effectiveness. So the Cobalt patients, as I said at the beginning, were a group who had both severe and chronic depression. They hadn't responded to antidepressant medication. So I think these findings of a long-term benefit should hopefully offer hope, really, to this group of patients whose depression is difficult to treat. And it's important that this represents good value for money from the perspective of the NHS. So going forward, it's important clinicians discuss referral for CBT with those for whom antidepressants are not effective. It also highlights the importance, really, of investment in psychological services. And it has been substantial investments in the IAP program already, but these have mainly increased the provision of low-intensity treatments, so guided self-help and computerized CBT packages. And if you look at data from the IAP services, we can see that on average, patients receive around 6 sessions of CBT through IAP, which is substantially less than the 12 to 18 sessions of high-intensity therapy as delivered in Cobalt. And so going forward, translating these findings will require more investment in the type of high-intensity treatment that we delivered in this trial. Thank you.
And I promise you, these are easy questions. So my first question then is, why are you involved in this research? Is there anything about this that particularly grabs you?
Okay, so I'm an epidemiologist by background, and my interests are in primary care and mental health. And I'm particularly interested in pragmatic trials to answer clinically relevant questions. So we came at this very much from the viewpoint of, knowing that there's this big problem in primary care in terms of non-response to antidepressant medication, and looking at the literature, trying to see, well, what is the evidence base for the next step for this patient group? And actually, when we do that, there's very little robust evidence in terms of either psychological or pharmacological treatments. And so that's where the interest came from, really.
And it's a really important problem, isn't it, for the country? Yes, yes. So what are your key messages for the audience to take away if they remember nothing else?
Okay. So the key messages really are around that this is very much about the long-term effectiveness of CBT for this patient group. And this is CBT that's given in addition to antidepressant medication as part of usual care, so it's an adjunct therapy. And I think that we need to clearly make sure that clinicians refer this group of patients for CBT. I think it's important to acknowledge CBT isn't for everyone. And that came out of some of the findings of the qualitative study which ran alongside the main trial. And what I think we need to do is to provide patients with more information about what CBT involves, so that they're clear that this involves not only a regular commitment to attend therapy sessions, but also understanding that this is an educational approach. It's about teaching them skills to help them manage their depression. And so that they will be required to do between session work. They'll have to try things out that therapists discuss with them in session, understand and see how that works for them. And I think if we do that, we'll enable patients to make a more informed choice about referral for CBT.
Okay, so can I push you a little bit harder on your results then? Because there was an improvement in the Beck score, and you say it was 19.2 versus 23.4. Is that a clinical significance?
Okay, I think it is clinically relevant. It's clinically important. If this is an effective treatment, both in terms of reducing depressive symptoms and improving, as I said, secondary outcomes of anxiety and quality of life. And the NICE guidelines group have suggested that a change of 3 points on the Beck Depression Inventory is something which could be considered clinically relevant. So using that as a benchmark, I think our findings, clearly suggest that this is an outcome which is relevant for patients. And I think the other comparison, if you like, that we can make is the results from other depression trials. Trialists often use a measure called effect size just as a way of expressing the difference in outcomes between treatment groups. And if you look at the evidence for other depression trials, you get an effect size of around 0.2, 0.3. The difference we saw in Cobalt over the long term equates to around 0.45. So I think we're talking here about larger effects that are clearly beneficial to patients.
And it's the long-term effect of the CBT that's just so special about this trial, isn't it? Okay, well, you're just the researcher, but my next question is perhaps, again, a bit difficult. What do you think? What do you think should happen next? How are we going to afford this?
How are we going to afford
this?
this?
Yes, because I can't get my patients into CBT very easily.
Yeah, no, I mean, that is, I'm glad I'm not a commissioner, I must admit. I think what we need to acknowledge is, the NHS 5-year forward view for mental health acknowledged that there needs to be more investment in psychological therapies. And earlier this year, July, the government announced plans for recruiting an additional nearly 3,000 therapists to support these talking therapies. I think that investment is going to be key. But I think it's also about, given these results and relating the findings, if you like, to the other depression trials and showing that this is an effective intervention over the long term, both in terms of benefits for the patient, but also in terms of value for money. And if we look at that relative to the evidence for low-intensity therapies, I think service providers and commissioners need to think about the distribution of resources, if you like, between low-intensity and high-intensity therapies. A lot of the investment in the IAP services has gone into low-intensity therapies, but as I say, we're showing here evidence of long-term effectiveness for this type of high-intensity treatment, that clearly is beneficial to patients.
So in 10 years' time, what would you like it to look like?
What I'd like it to look like? I think really we need to think about moving forwards and thinking, can we improve efficiency in delivering treatments? We need to think about understanding more about how treatments work, including CBT. There isn't actually that much robust evidence about how CBT works. And we want to use really, I think, advances in technology to think about how we can deliver technology-enabled services to really allow us to improve efficiency and delivery of services for patients, and also hopefully increase access for those who may not otherwise be able to access these services. I think that's the only way we're going to be able to improve outcomes for patients.
Really, really useful and important piece of work. Thank you so much, Nicola, and thank you for answering my questions.
Right.
And well done.
Thank you. Thank you.